Thank you very much for a very nice introduction. I would like to correct that I'm not a section head anymore. It's Dr. Professor Mohammed Irfan. Thank you very much again. I decided to change the topic. I said pulmonary medicine needs different subspecialties of internal medicine. So that's what I'm highlighting today. I don't have any medical disclaimers. This is the picture I took yesterday from my room at Serene. So these are our old, good old friends who are with us, and it has been highlighted by the previous two speakers that how important it is to take a detailed history. So I'll be presenting two cases. Initially, I thought it should be more interactive, but because of the lack of time, I will just go through it. The first case is referred by my ex-favorite fellow, 48-year-old male. He was a lawyer from Bahawalpur, and he presented to his hometown to a rheumatologist in 2019 with a history of acute onset pain, stiffness of small joints of hands and shoulders, difficulty lifting weight and climbing stairs. He had no comorbidities, he had no addictions, family history was unremarkable, there was no documentation of physical exam findings at that time, but जो लेके आते हैं patients labs उसमें mildly positive ANA and elevated CPK was reported. He was treated as so-called CTD with prednisolone and plaquenil for 6 months by the rheumatologist, and he went into remission and did well till 2021. And then he presented to my colleague and ex-fellow in Bahawalpur with 1-year history of progressive shortness of breath. Now we are in 2021. He had a significant exposure to pigeons, parrots, and chickens for 2.5 years in garage. Reported to have bibasilar crackles on chest auscultation. He had an HRCT done in his hometown which showed bilateral GGOs and reticulation. His spirometry showed restrictive lung defect, and he was diagnosed as probable HP, hypersensitivity pneumonitis. He was started on oral prednisolone in November 2021, planned to start as a thioprin, but unfortunately it was not available. This is a poor quality CT scan done over there. You might see some ground glass, but as I said, it's not of a very good quality. So my question was, what do you think is the most probable diagnosis, HP, MCTD, IPAF, or you are not sure? Does anyone want to answer real quick? Okay, all right, yeah, IPAF, or you can also pick, I'm not sure, okay, by history HP is, of course, is in the differential. We don't have a very good quality CT scan, which the previous two highlighters have, have already highlighted. So he developed worsening of symptoms on steroid taper. He was on 5 milligram, prednisolone was increased again, he improved and then deteriorated again. He was referred to be the ILD clinic. History was almost the same as described. Physical exam showed no clubbing, no synovitis. Musculoskeletal and neurological exam was normal. He had RALs on chest auscultation, which was not Velcro type. And the autoimmune panel revealed that he has an ANA 3+ in a nuclear envelope pattern with the titer of 2,560. He had mildly elevated rheumatoid factor. His ESR, CPK, and aldolase was slightly elevated, but these two were normal. The rest of the autoimmune profile was negative. So let me just run this. Yeah, you will see over here to run this video. Here you go. Thank you. So you can see this HRCT video. There are, ground glass opacities actually involving all the lung zones, but maybe a little more in the lower lobes. It is running a little too fast, but I will show you some of these sections over here that there are patchy ground glass. And here is the lower lobe cuts, which is a little more denser over here. There is no honeycombing. There's some reticulation as well. So what you don't know because you're not a radiologist. Quick. NSIP, all right. So I I decided to do an extended autoimmune panel on this gentleman, and it showed that this was anti-coup antibody was positive. 2023 में अब हम आ गए. He developed a skin rash. Before that, he was started on mycophenolate mofetil, seen by dermatologists. The LFTs were deranged. It went 5 times above the normal limit. The dermatologist thought that this could be due to MMF, although I was not very much convinced. The prednisolone dose was increased by dermatologists to 15 milligram. And here you can see the trajectory of the pulmonary function testing that has forced vital capacity, which was 60% in 2021, and now we are in 2023, it dropped by almost 30%. We didn't have DLCO in the initial 2 years, but in 2023 it was quite low at 40%. So he definitely has a deterioration of disease. We were unable to taper prednisolone below 15 milligram. I discussed this case with my rheumatologist. We decided to give him 2 doses of rituximab. The first one was given in June, and another one was repeated in July. He had marginal improvement in dyspnea. He was advised to see a rheumatologist again. He underwent further diagnostic workup, which include MRI of the thighs, inflammatory myopathy, nerve conduction study was normal, and CPK, aldolase, and ALT were also not markedly elevated. He went to his hometown again, and he saw one of our esteemed panelists over here, and we discussed this case, and we decided to do the fluoroscopic evaluation of the diaphragm. I think this is not going to display here, but let me, oh, here it does, okay. So you can see that the diaphragm, he has small lung volumes, and the diaphragms, are quite high, and the right side is, I think, is a little more involved than the left side. So he definitely had the diaphragmatic involvement. Has improved, and he's mashallah doing well. He's supposed to see me in clinic next week. Very quickly, second case, again referred by one of my fellows. This time this is a lady referred from Quetta. She initially presented to dermatology clinic with itchy erythematous wheals all over the body, no triggers identified, no angioedema, choking, or dyspepsia, diagnosed as chronic urticaria, treated with multiple medications for 2 weeks, no improvement, referred to allergist, immunologist, and rheumatologist. The detailed review of systems showed that this lady had polyarthralgias, rash, excessive morning stiffness, photosensitivity, oral ulcers, and known productive cough. So, of course, the history is extremely important, and definitely she had some sort of autoimmune disease. She had hair loss, graying of hair at age 23. She was treated with minoxidil perfect. That she had 1 miscarriage at 6 weeks. She was a nursing mother at the time when we saw, no addictions. She was a housewife. Physical exams she revealed she had facial telangiectasia and erythematous rash all over the body and bilateral crackles on chest auscultation. This is how the rash looked like. She was diagnosed as hypersensitivity vasculitis by the dermatologist and rheumatologist. Treated with colchicine for 4 weeks. The ANA was negative, but RA factor was positive. I didn't have her titers because it was an outside, sorry, it was 23.8. So it was slightly elevated. CRP and ESR was also slightly elevated. She was referred to my clinic for 3-week history of non-productive cough and shortness of breath. She was found to be hypoxic with oxygen saturation of low 80s. She was advised further diagnostic workup and started on prednisolone because sometimes you don't have time to wait for the laboratory investigations. So if your patient is sick and hypoxic, so you have to start treatment along with your diagnostic evaluation process. So she was given 0.5 milligram per kilogram per day, and eventually mycophenolate was added with PJP prophylactic. Markedly positive at a titer of 5,120 in a ribosomal pattern, and the ACCP, ENA, and ANCA were all negative. The pulmonary function test showed forced vital capacity of 50% predicted and the DLCO of 59%. So this is her CT. So this is the first time she had a CT done. So right now she was, so you can see this CT is much more worse than the previous one. There is what we call, this is the traction bronchiectasis. There's patchy areas of some forming consolidation and along with ground glass opacity. Still, there is no significant honeycombing. Oops, it's running again. Seven minutes left, so I will try to, once we finish with these cases. Right. So these are the slides. You can see that it is much more, denser in the lower lobes again, but it's starting right from the apex. And you might appreciate that there is subpleural sparing, as previous speaker has pointed out, that this is one of the pattern. So what pattern do you think it is? It is UIP, NSIP, OP, or OP, NSIP combined pattern? All right, very good. So steroids are gradually tapered to 15 milligram. MMF was increased to 1.5 BID. Hydroxychloroquine was added by rheumatologists. Further diagnostic testing was advised, but she was migrating to Australia. So that panel was done over there, and it was found that she was anti-Rho 52 and anti-PL12 was positive. So this is the X-ray how it looked like. This was 1 year prior to presentation in pulmonary clinic, and you can see how bad it was even at that time. But there was a significant delay until she was referred to the pulmonologist. In 2024, she was still coughing and had progressive dyspnea. There was a decline in DLCO. And rituximab, I decided to give her 2 doses, 15 days apart. She was visiting Karachi, and alhamdulillah, she did well, and now she's back in Melbourne. So other speakers have already talked about it, so I don't want to spend too much time, but I want to show you the paradigm shift, that this is our national ILD registry, started by Professor Musawwar Ansari, and we published that a couple of years back, in which many centers were involved, and it was the number 4 diagnosis in our cohort. And this is the AKU ILD registry, and now you can see that this is the number 1 cause of interstitial lung disease, at least in my institution and in my practice. Whereas IPF is now number 2, and there's a significant difference, 127 and 141. HP is number 4, and then during the COVID era, we saw some cases of COVID ILD as well. And in CTD ILD, the most common one was a rheumatoid arthritis, but I have a cohort of IIM patients, approximately 13 patients. So serologies, ANA by immunofluorescence, please try to get it from a reliable lab. which is doing it by immunofluorescence technique and give you a titer and pattern. Just giving an ANA report of positive doesn't help. And remember that 18% of the population may have positive ANA in mild titers, and 23% over age of 50, particularly in females, have a high risk of developing autoimmune disease, particularly if their ANA titer is more than 160. So if it is more than 160, that is an alarming bell that there's something going to happen. If it is not happening at that time, maybe in the future, and then there is a battery of other tests that you can order. So this was a gentleman, Henry G. Krunkel. He's an immunologist who discovered ANA different patterns of ANA. I don't have time to go through the details of this, but whatever, ILD, association with autoimmune disease is, there is a pattern which is not only in the radiology, but also the histopathological patterns that we combine that was being highlighted by the previous speaker. But polymyositis and dermatomyositis, ILD seen in 20 to 90% of cases, and the most common pattern is NSIP, but there are other patterns described in the literature as well. If you have a good radiologist, believe me, it is a blessing. But remember that the radiologist is not a magician. So if you go to the radiologist and ask him what is the diagnosis, that is not correct. The radiologist will tell you this is the pattern, and now it is the responsibility of a clinician to decide that what particular ILD it is. There are 4 patterns, which I think we're going to hear from the next speaker in detail. Very briefly, in idiopathic inflammatory myopathies is a group of disorders that rare causes, which constitutes dermato, poly, overlap myositis, whatever patient had, inclusion body myositis, and then there's another category called necrotizing autoimmune myopathy. And this is the gender and pattern of weakness. Because of the lack of time, I'm just going to share with polymyositis, which is more reported in females, proximal more than distal weakness. Serum CPK can be elevated more than 5 times of the normal value, and the ANA is positive, and it has an association with the ILD, malignancy, vasculitides, and CTT. And here is the slide which shows you that the lung disease is very commonly reported in anti-synthetase syndrome, and there has been association with the malignancy as well, as we saw the case yesterday. Clinically, amyopathic dermatomyositis, remember that there is a subset of dermatomyositis in which there is cutaneous manifestation of 6 months or longer, and they may not have proximal muscle weakness. They may have normal or abnormal enzymes, EMG, and your muscle biopsy, but not necessarily. So there are 2 subtypes described. One is amyopathic or ADM, and one is the hypomyopathic. And it has a strong association with which we call anti-MDA5. So these are the pictures. So HNP first, and then myocyte-associated antibodies. I'm going to skip this. Anti-Ku antibody syndrome. This has an association with the different autoimmune diseases as listed over here. So there was a very nice paper published in Medicine in 2012. It's a little old, almost a decade old, but it highlights the different etiologies that has been reported with anti-Ku antibody. But remember that there is an isolated interstitial lung disease associated with anti-Ku antibody has also been reported. Treatment has also been highlighted by the previous speaker, but it depends, how severe the disease is. The glucocorticoids are given in a relatively higher doses, 0.75 to 1 milligram per kilogram per day. You can pulse them if they present with hypoxemic respiratory failure, and then you can consider these alternatives in a sick patient. And if for the maintenance therapy, you can MMF or azathioprine. I prefer MMF, but there's second-line agents as well. And then you can go to rituximab if your patient is not responding. So I would like to conclude my presentation that think about IIM-ILD in patients who have unexplained interstitial lung disease or the routine autoimmune workup is negative, but you still think that there's something autoimmune. Diagnostic delays are common. Routine autoantibody testing often fails to detect IIM syndrome. MDD is essential for early diagnosis and management, and ILD is a major cause of morbidity and mortality in these patients. Thank you very much for your attention.